I'm Carole Taylor. On this edition of Journal, we take a closer look at the safe supply of drugs in British Columbia. This refers to the distribution to drug addicts by the health authorities of a drug called hydromorphone, an opioid some say is as potent as heroin. Now, the idea behind this initiative is to move individuals away from the toxic street drugs that are causing so many overdoses. But are they safe as we understand the word? A proposed class action lawsuit has been filed in the BC Supreme Court suggesting this terminology is negligent misrepresentation and that they're not safe for our community. An earlier report by an American drug policy expert, commissioned by Bonnie Henry, our own medical health officer, stated that rampant safe supply diversion is all but inevitable. Now, diversion means that while these drugs are initially given to drug users in the program, they are often traded for cash or stronger drugs on the street. These dillies, as they are called, often end up in the hands of our young people and even in our high schools. Police have been quoted as saying that every day our officers observe people openly selling these diverted safe supply medications. This means that these drugs are often not staying with the intended user for the intended purpose. And this increases the potential of expanding our drug-using community rather than decreasing it. The reporter who has been meticulously documenting these issues in the National Post is Adam Zivo, the Executive Director of the Center for Responsible Drug Policy. Adam joins us after this break to discuss the complexities and consequences of our drug policies. Adam Zivo joins us today, and Adam, you've done so much research and writing about the question of safe supply. And as I was reading a number of your columns, it made me think, where did this idea of safe supply come from in the first place?
Well, the theory behind safe supply is actually fairly reasonable. The idea here is that it's very difficult to get people onto traditional opioid addiction medications like methadone and Suboxone, partially because fentanyl has left people with very high tolerances. So historically, if you wanted to treat someone for addiction, let's say they're addicted to heroin, you titrate them onto the appropriate dose of methadone, and that would take maybe just a few days. Methadone is a kind of long-acting opioid that you take once a day. You give just enough to manage withdrawals without enough to induce euphoria. But then fentanyl came in and people started dying at much higher levels because fentanyl is 50 times stronger than heroin or comparable opioids. And because people who are addicted to fentanyl, they have really high opioid tolerances, it takes approximately 2 weeks to get them onto methadone or Suboxone. And 2 weeks is a lifetime for someone who is struggling with addiction. So traditional opioid medications were not working as well as they used to, and people were dying at much greater numbers. So the idea, theoretically, was to give people a safer supply of opioids to keep them alive until they would be ready to seek treatment.
And so it then evolved into the situation we've got today. You came across the report, Calkins report. Talk to me about that.
So the Calkins report was commissioned by Bonnie Henry, who is BC's top doctor, back in the autumn of 2023, if I remember correctly. And this report was supposed to look at the economics of safer supply, how it would impact the potential black market. And it was kept very secret at first, to the point when its existence was leaked back in April of this year. EB claimed that he had no knowledge of it. So eventually it was published in, I believe, June or July of this year, at the exact same time that Bonnie Henry published a report advocating for the full legalization of drugs through non-medical safe supply. And because the report was published at the same time as this other explosive report, it was essentially missed. For myself and many of my contacts, we watched this conversation quite closely, and all of us failed to notice the fact that the Calkins report was put out. Now, what the Calkins report found was that it was pretty much expected that a large sum of safer supply opioids would be diverted, that it would be foolish to imagine that we could give out a commodity with a monetary value for free and not have some of it resold on the black market. On top of that, one thing that I found particularly concerning was that Calkins was given access to PharmaNet data. So PharmaNet is the province's prescription monitoring system. And through that data, he was able to estimate that Safer Supply had expanded the province's pharmaceutical opioid market by about 30%. And this is really relevant because the harm reduction activists keep on saying that there's no possible way that Safer Supply diversion is warping the overall drug market because there's only approximately 4,500 patients, which is a very small number. But they receive so many opioids per person every single day that they basically expanded the pharmaceutical market by 30%. So much of it is going to the black market, and now we see the price of certain opioids on the black market crashing.
So in the first place, when you talked about, this is a good idea, government talked about it being a good idea, were they basing it on research? Did they have data that showed that this approach of giving out the medication more freely works?
Absolutely not. So they based their policymaking off of research produced around something called IOT, so injectable opioid agonist therapy, which is essentially using pharmaceutical grade heroin as a way to manage people's withdrawals to help them titrate onto weaker addiction medications like methadone and Suboxone. However, our trials for IOT were conducted under strict supervision and were never really meant to induce euphoria. It was a form of withdrawal management. So what they said is, okay, this works. So what we're going to do is we're just going to give people bottles and bottles and bottles of hydromorphone, which is a pharmaceutical opioid that is an equivalent of heroin with no supervision at all, with no additional supports for the most part, and we'll just assume that it works. But that intervention is very different from what IOT is, and basically the evidence base was non-transferable. On top of that, so Safer Supply was first piloted in London, Ontario in 2016. And so between 2016 and 2020, they did a number of studies and evaluations on Safer Supply in Ontario, and they claimed this was an evidence base. But when you look at the evidence base, it's incredibly weak. The vast majority of the studies that on Safer Supply were basically just interviews with patients who were on Safer Supply, asking them, hey, what do you think about this program where you receive free pharmaceutical opioids? Do you like it? Does it help you? Are you selling it on the black market? And when these addicts said, no, of course we would never sell it on the black market, and it's great, researchers framed that as reliable, objective evidence, even though the vulnerability to bias was so huge.
And I also felt there was a bit of a wall up about talking about diversion and the fact that these drugs were being resold, on the market. I thought that there was a way that these pills could have been made with markers so that we would know exactly if these were out of that supply system.
Well, that's the thing. This is the kind of thing where Safer Supply drugs should have tracing elements in them. And there's a variety of different ways you can do this. For example, you can use special packaging, but then the gap there is, of course, that people can always just take the Safe Supply out of the packaging. That's what drug dealers often do. You can give special dyes and special shapes, but then that's also easy to overcome because you can crush your Safer Supply drugs, or you can dye them if you're trying to resell them on the black market. But the last thing is you can add chemical identifiers, and this is already done quite widely in the United States to catch counterfeit drugs. And for some reason, the federal government refuses to add these tracing elements, and Safer Supply advocates will claim that it's stigmatizing to include these tracing elements, which doesn't make any sense. Because if you're using your Safe Supply drugs on the streets and you have a chemical tracer that's not even visually discernible, then how is that stigmatizing? And it seems as if there's a lot of resistance here because if we could measure diversion, we'd be able to quantify the harms of Safer Supply, but that would open up the federal government to a lot of political and legal liabilities.
So this is federal, that question.
It's federal to a certain extent. I mean, Safe Supply is a combination of federal and provincial policy. It's essentially prescribing high potent, like very potent opioids off-label. And the federal government funds Safe Supply programs throughout the country, and then, of course, has some powers to regulate medications going throughout Canada. But it's not all just a federal thing.
And so who were the influencers that within government, within the healthcare system that said, this is a good idea, we're going to push it?
Well, I mean, the Trudeau government has been a very strong champion of safe supply. Carolyn Bennett, who was the former Minister for Mental Health and Addiction, was a staunch advocate, even though she didn't even know the difference between safe supply and safe consumption sites, which are two totally different things. She actually mixed them up in Parliament, which is absurd. And now Yara Sachs, who is the current Minister of Mental Health and Addiction, is a giant advocate for safe supply, even though she has no relevant qualifications in healthcare. From my understanding, before she became minister, she went around and spoke with physicians and didn't ask them if safe supply worked. She asked them how she could defend safe supply from the Conservatives because it was a political issue for her. The public health bureaucracy at all levels of government are very strongly for safe supply, mostly because these bureaucrats, these policymakers, don't have any clinical experience. So you're talking about people who maybe got a master's degree in public health, didn't do much work on the front lines of the addiction crisis, and see this thing and say, oh, it sounds great in theory. Oh, we have some studies that seem to say that it works. We're going to ignore all the obvious holes. And then they're ignoring the addiction physicians who are actually treating people on the ground and saying that this isn't working.
And so we find ourselves in this very difficult situation. We'll continue our conversation with Adam right after we take this break. We've been talking about the difficulty of diversion of these safe supply drugs, but at least at the moment they're given by prescription. And it was really surprising when our former coroner came out with a report, along with Bonnie Henry, our medical health director, saying, well, we shouldn't even have prescriptions, like don't even bother. So no touch with the medical system, just here are your drugs.
Well, so the reason why they want this is that many of the advocates who are pushing safe supply, they actually are drug legalization activists who see safe supply as a stepping stone towards a society where you can get any kind of drug that you want in a store, much like cannabis or alcohol. So Lisa Lapointe, who is the former chief coroner, who once again also has no medical degree, no medical background, has been a huge advocate. And Bonnie Henry, of course, released that aforementioned report this summer pushing for non-medical safe supply. Now, if you read through the report, you'll realize that she actually has no evidence that legalizing drugs at all would be beneficial. So she actually acknowledged in the report that no jurisdiction has legalized drugs in the way that she's recommending. But what she said is, well, if safe supply in its current form works, then I guess that means that safe supply in a non-medical form would work. And as I mentioned earlier, like the evidence base for medical safe supply is really low. So to try to extrapolate from that like a non-medical model would work is insane. Like once again, two totally different interventions with a non-transferable evidence base, with the existing evidence base for the more limited model already being very weak. So she was basically just pushing evidence-free policymaking in that is highly risky, that could kill people. And I thought that was really reckless. And when you look at some of the other aspects of the report, like the reasoning was really bizarre. So for example, she argued that, oh, we should simply regulate drugs in the same way that we regulate clothing, that we regulate toys, right? And basically saying that, we need to have consumer standards. But the thing is that if you legalize a commodity, you increase its supply, you increase its availability, and that increases consumption. And that's okay if we're talking about teddy bears or fruit salads. There you want to regulate, you want to make sure that there are certain standards. But when you legalize drugs like fentanyl, like cocaine, like meth, and you make it more available and use increases, that costs lives, right? And then there was this utterly bizarre section where she argued that we need to legalize drugs because it would be racist not to. That drug criminalization is rooted in racism, colonialism, white supremacy. And when you look at the report, pretty much all of the authors are white. And it really shows, because if you speak with any racialized voter in Canada or in the United States, the vast majority of them don't want drug legalization. Many of them have historical traumas pertaining to drug use. I mean, First Nations are very anti-drug because they saw what happened when their communities were plied with alcohol 100, 200 years ago. Chinese Canadians and Chinese Americans are very anti-drug because they remember the traumas of the opium wars in the 19th century. When we look at the world today, the countries that are strictest in their drug laws tend to be East Asian and Middle Eastern. So this narrative that it's racist to criminalize drugs doesn't make any sense. It's basically progressive white people projecting their radical politics onto racialized communities.
And so, fortunately, Premier Eby immediately stepped on that report and that suggestion and said, no, we're not moving away from prescriptions. So that was positive. But you talk about the harm that can be done. And I think one of the biggest harms is the expansion of drug users, because we're seeing it. We know that's happening. And it was heartbreaking to me, a front page story about Camilla, because here was a young 13, 14-year-old girl. And her father says she actually believed, because the government said it was safe supply, that these were safe drugs to start taking. Yeah. Tell me her story.
Well, so Camilla Sword was a 14-year-old girl whose mental health destabilized during COVID, and she fell in with the wrong crowd. And they started experimenting and consuming safe supply hydromorphone. Once again, hydromorphone is an opioid that is essentially heroin. And they would get it from a drug dealer, who I actually interviewed earlier this year, who would purchase it from safe supply patients downtown, in the downtown east side. So this drug dealer would go and buy hundreds of safe supply pills every single day that he worked in the downtown east side. He would get it from safe supply patients in their prescription bottles, the same number every day, 14 pills, which is the maximum you can dispense under provincial guidelines. And then he would go back to his trap house and he would put them in a big bag, and then they would ship it all across the country. He would take his extra pills and he would go to Port Coquitlam and he would sell them to Camilla and her friends. And he would tell them that it was just pain medication. It was safe, it was fine, it was from the government. And they didn't know. And it was incredibly cheap for them. You know, these pills used to cost $20 each before Safe Supply. Now they cost $1 to $2. He would buy them at that price and resell at $5. So they got hooked. Camilla's friends ended up escalating to fentanyl and then ended up going to rehab, but, you know, destroyed their youth. And Camilla, unfortunately, died of drug-related causes approximately 2 years ago after developing this addiction. So now her father and the mother of one of her close friends have launched a class action lawsuit against the federal government and provincial government for recklessly marketing these drugs as safe and for tacitly condoning the widespread diversion of safe supply drugs.
I thought it was really understandable and amazing when you heard her story that they're called safe, they're from the government, and they have some fun at a party, and as you say, very addictive drugs.
Well, here's the thing. What I find so pernicious about the safe supply thing is its impact on youth, and there are three main factors that that impact use of a drug. So availability, affordability, and perception of threats, right? So safe supply hydromorphone is now highly available. It's highly affordable, and youth don't know what it is. So you go to a teenager and you say, hey, do you want to try some heroin? They know that heroin will destroy their lives. And so they're very reluctant to try it, especially if they have to snort it or inject it. But if you come up to a kid and you show them a pill and you say, hey, try this pill, it's hydromorphone, it's just a pain medication from the government, they don't know what it is. They have no clue that it's basically heroin, and they'll be open to experimenting with it. And then they only realize what they've gotten into once they're already hooked. And by that point, it's often too late.
Do you think the lawsuit has any chance?
I think so, because I think that it is well documented that the government negligently marketed these drugs as safe. And on top of that, many government, like stakeholders related to the government, published documents actually advocating for diversion or defending diversion. There's this one awful guideline that was published in 2022, I believe, called Reframing Diversion. It was published in Ontario by a organization that was funded by the federal government to distribute safe supply. And they basically advise doctors to look the other way if their patients were diverting, because diversion is a good thing and it's an act of mutual care.
I don't even understand how they could argue that.
The way that they saw it is that, oh, if people mass divert their safe supply drugs, that will displace the illicit market. And I have spoken with safe supply prescribers who used to support that system because they thought that this would be the case. But we can now see that it's not, replacing the toxic illicit drug supply. It's merely expanding the overall drug market. I've spoken with numerous police stakeholders in Ontario where hydromorphone seizures have increased by 1,000 to 3,000% since safe supply became widely available. And they emphasize that based on what their officers are seeing, mass diversion is not leading to a less toxic drug supply. It's leading to just more drugs for everyone to get addicted to.
And so what's the first step getting out of this mess?
Make witness consumption a mandatory aspect of safe supply. No more handing people bottles to do whatever they want with. It needs to be witnessed so that diversion cannot happen.
Are you hopeful?
I think so. I know that the federal government has been rolling back on safe supply, so they've defunded many of their safe supply programs. And from what I'm hearing from my contacts, they privately realize that this has been a giant mistake, but they refuse to acknowledge this publicly.
Well, thank you, Adam, for the work you're doing, continuing to do your research and informing all of us. It's a serious, serious problem in our community. Thank you.
Well, thank you for having me on the show.
Back in a moment. Drug addiction, harm reduction, recovery treatment, overlapping and complicated problems for a society to take on. Well, I don't think there's one right answer. We must ensure that our well-intentioned policies are not making things worse. Today, around 6 people are still dying every day from overdose in BC, and our drug user base is expanding. Not good enough. Let me know your thoughts on YouTube. Till next time, I'm Carole Taylor.